Hello. In this session, we shall review common bacterial infections which may involve the oral cavity. This session is recorded as a PowerPoint show, and you should be able to click each slide and listen to the associated audio presentation with each slide. The aims of this session are to develop an understanding of the presentation of bacterial infections in the oral and maxillofacial region. And by the end of this session, you should be able to discuss the following: primary bacterial infections of the oral cavity and systemic bacterial infections with oral manifestations. During this session, we shall look at the causative microorganisms for each of the bacterial infections, the clinical presentation of the infection, laboratory diagnosis, and general management principles. As you may appreciate, the most common bacterial infections involving the oral cavity come from odontogenic sources. So, for example, infected tooth pulp, infected periradicular lesions such as abscesses, granulomas, or cysts, uh, and most odontogenic infections have a mixed bacterial population. The important thing is that odontogenic infections should not be taken lightly, as they can be potentially life-threatening if left untreated. I believe you would have had some teaching on general bacteriology, gram staining, and classification of bacteria, and I'm not going to go into the details of those topics, but I'd just highlight a couple of points. So from your previous knowledge, you would be aware of the basis of gram staining. So the initial stain which is used in gram staining is crystal violet, and bacteria which take up this stain and resist decolorization by alcohol and water are termed gram-positive bacteria, and their colonies appear dark blue or purple, whereas gram-negative bacteria are decolorized and take up the counter stain, which is saffronin or fuchsin, and their colonies appear pink. Two of the most common gram-positive bacteria in the head and neck region are uh, Staphylococci and Streptococci. Staphylococci are obviously found more on the skin, whereas Streptococci have a much wider distribution. Streptococci are classified on the basis of the type of hemolysis which they produce on blood agar plates. As you would know, blood agar is a common uh, culture medium used for bacterial isolation, and streptococci, which produce partial hemolysis of blood agar and have a greenish appearance on blood agar, uh, they are termed alpha hemolytic, and these include strep pneumoniae, which can lead to pharyngitis and is also involved in pneumonia and several other infections, and strep viridans, which includes important species such as strep mutans, strep sanguis, and can also be involved in infective endocarditis. Beta hemolytic streptococci lead to complete hemolysis of blood agar and produce uh, clear colonies, and these include strep pyogenes and agalacti. And finally, gamma hemolytic streptococci do not produce any hemolysis on the blood agar and are mainly bacteria involved in intestinal infections or enterococci. Perhaps the most well-recognized and commonest infection in the oral cavity is a dento-alveolar abscess, which is caused by a mixed bacterial population dominated by anaerobes such as Fusobacteria, Porphyromonas, and beta hemolytic streptococci. In the images on the left side, you can see a dento-alveolar abscess associated with the maxillary central incisor, and you would note that the bone on the labial aspect of the upper central is thinner, and pus tends to drain along the path of least resistance. So an abscess associated with the upper central is more likely to perforate the bone on the labial aspect, leading to an inflamed swelling uh, on the labial bone with discharge of pus. On the other hand, the maxillary lateral incisor root has a palatal inclination, which makes the palatal bone much thinner compared to the labial bone, and therefore abscesses associated with the maxillary lateral incisors tend to drain along the palatal aspect of the maxilla. Uh, so remember that abscesses are localized collections of pus, and the important thing is whatever measures you adopt, your aim is to drain the abscess. Antibiotics are an absolute no when it comes to treatment of abscesses. Abscesses need to be treated by incision and drainage. So if you apply that principle in the oral cavity, how are you going to incise and drain the abscess? You basically have three options. If the tooth is restorable and you think you can save the tooth, you can drain the pus through access opening in the root canal. Uh, if the tooth is not salvageable, then extraction is an option, and obviously once you extract the tooth, the pus will get a path of drainage. On rare occasions where operative treatment on the tooth is not possible, uh, there is the possibility of incising the abscess through a stab incision, uh, either intraorally, or if the abscess is visible extraorally and there is a clinical indication, on rare occasions you can even drain the abscesses extraorally. Apart from causing an abscess, odontogenic infections may spread through the tissue spaces and lead to a spreading infection or cellulitis. This is a much more severe form of infection which tends to involve the tissue spaces and is more likely to be complicated with sepsis. Uh, as a dental professional, you should have the ability to differentiate between an abscess and cellulitis, because an abscess can be treated in primary care in the dental practice settings. However, if your patient develops cellulitis, they need to be referred to the hospital to be managed as inpatients. So just for the sake of your understanding how cellulitis spreads, this is a topic in its own right, and you will have a separate plenary on the clinical presentation and management of cellulitis, but I'll just highlight some key points. So if you look at this maxillary molar, infection from the maxillary molar can spread towards the palate, which is marked as number 3. So that's the palatal space, and from there it can spread further into the lateral pharyngeal or retropharyngeal spaces. Similarly, infection from the molar can drain into the buccal vestibule, so where you would see a vestibular abscess or vestibular swelling. However, if the roots of the molar are apical to the attachment of the buccinator muscle, so that's the buccinator muscle, which is attached on the buccal aspect of the maxillary and mandibular molars, the infection can go into the cheek, which we term the buccal space. So a vestibular infection is different from a buccal space infection. Also, infection from the maxillary teeth can involve the maxillary antrum and lead to sinusitis. When you look at the mandibular molars, for example, if the roots of the mandibular molars are coronal to the attachment of the mylohyoid muscle, infection will involve the sublingual space. However, if the roots of the molars are apical to the attachment of the mylohyoid muscle in the mandible, then infection would possibly be transmitted to the submandibular space. So this is a classical example of Ludwig's angina, which is bilateral cellulitis involving the submandibular and sublingual spaces. And you can clearly see, because of involvement of the sublingual space, the tongue is pushed outside because there is insufficient space in the mouth to accommodate the tongue, as involvement of the sublingual space leads to the floor of the mouth being raised. And infection in the submandibular region can compress the upper airway, and you can see a tracheostomy tube in situ in this patient. So that's why patients with cellulitis need to be managed in hospital settings, because cellulitis can be life-threatening and prescribing antibiotics would be a disservice to the patient. So as soon as you recognize that the patient has signs of cellulitis, you should immediately call the local MaxFax department in the hospital and refer the patient for management of the patient on a maxillofacial ward, where they'll be given IV fluids, IV analgesics, parenteral nutrition, and the clinicians at the hospital will determine if the airway is at risk and whether they need to take additional measures to protect the airway, such as tracheostomy. As I said, it's a separate topic in its own right. We can't discuss it in to the full extent in this presentation, and we'll have a separate session on this topic. But so that you remember that dento-alveolar abscesses and cellulitis are bacterial infections and represent one of the more common types of infections in the oral cavity. Now we shall discuss two skin infections involving the face, which are not necessarily commonly seen in dental practice settings, but it's important for you to be aware of these infections so that you can recognize and refer these patients appropriately. The first one is impetigo, which is basically a superficial infection of the skin and can be caused by strep pyogenes or Staph aureus. It develops in the skin affected by dermatitis or trauma, and impetigo is mostly seen in people with poor hygiene who live in crowded conditions or hot and humid climates. So in the UK, for example, people affected by homelessness and poor living conditions may be affected by impetigo. And the classical manifestation is that fragile vesicles develop on the skin of face, extremities, and these fragile vesicles eventually rupture to leave crusted lesions, as you will see on the next slide. These images show classical lesions of impetigo. You can see crusted lesions involving the upper and the lower lip, and similarly in immunocompromised patients you can have extensive circumoral lesions on the face. Obviously, if the infection is less widespread and you see a single crusted lesion, you may possibly confuse it with cold sore or some of the other oral viral infections. So it's important that you evaluate the patient, and if you are unsure, it may be best to have a second opinion from the patient's GP. Another bacterial infection which can be seen in the head and neck region is Erysipelas, which is superficial infection of the skin, again caused by beta hemolytic streptococci or Staph aureus, or both. The infection in Erysipelas tends to spread through the lymphatic channels in the skin and can affect both young and elderly, and particularly immunocompromised patients are more at risk. It can lead to erythematous changes on the face, producing rashes. On this occasion, you can see a rash involving the right cheek and circumorbital region of the patient. But if it is bilateral, it can lead to what we call a butterfly rash, which is also seen in another condition, if you can think about it. I'll give you a second. Systemic lupus erythematosus is also characterized by a butterfly rash. So both impetigo and erysipelas can be managed by improving the patient's hygiene and identifying and managing any underlying immunosuppression. And the treatment also involves administration of antibiotics. But obviously, as a dental professional, you're not going to do that, and it may be best to refer the patient either to their GP or to the local hospital. A well-recognized bacterial infection in children is scarlet fever, which is caused by beta hemolytic streptococci. The infection initially manifests as pharyngotonsillitis, followed by development of fever and a rash 1 to 7 days after pharyngitis, which is caused by the release of erythrogenic toxin by streptococci. It's most commonly seen in children of 3 to 12 years and often involves manifestations on the tongue. The tongue initially shows a whitish coating uh, in the first 2 days, followed by erythematous patches on the skin. Hence, the term strawberry tongue is used to indicate tongue lesions associated with scarlet fever. So now you know that strawberry tongue is basically a manifestation of scarlet fever, which is caused by beta hemolytic streptococci. And again, as a dental professional in the primary care, you're not going to treat it yourself. If you see patients with this condition, it may be best to refer them to the patient's GP or to the local MaxFax department. Syphilis is a well-recognized sexually transmitted disease which is caused by chronic infection with Treponema pallidum. This microorganism is classically observed using dark field microscopy, and you can read more about it in your self-directed learning. Uh, the earliest records of syphilis date back as far as the 15th century, and it has been a challenge for the healthcare professionals for several centuries. However, towards the end of the 20th century, the incidence of syphilis seemed to be on the decline. But recent figures from the NHS show that it may be actually striking back again. For example, in 2017, there were 1,000 extra cases diagnosed in the UK, which equated to approximately a 20% rise in the incidence of syphilis in the UK. So that's something we need to be aware of. Syphilis classically passes through several stages: primary, secondary, and tertiary syphilis. Primary syphilis manifests 3 to 90 days following the sexual contact, and the lesions in the oral cavity, lips, or the genitalia generally heal in 3 to 8 weeks' time. If syphilis remains untreated, it can manifest back in another 4 to 10 weeks and may take up to 3 months to heal. Following that, syphilis may go into a latent phase only to manifest as tertiary syphilis. The latency period can be highly variable, anywhere between 1 to 30 years. However, tertiary syphilis is the most severe form of the disease and can be associated with significant complications, including the cardiovascular system, such as aneurysms of the aorta, left ventricular hypertrophy, or the CNS, where it may manifest with psychosis, dementia, paralysis, and muscle incoordination disorders. Finally, syphilis may also be passed from the mother to the fetus and may manifest as congenital syphilis, and we'll discuss each of these separately in the next slides. The classical lesion associated with primary syphilis is chancre, which is basically an inflamed, ulcerated lesion seen on the tissues involved during sexual contact. So on this slide, you can see a chancre involving the anterior part of the tongue. Similar lesions can be noted on the external genitalia in people affected by primary syphilis. If primary syphilis is left untreated, it can come back as secondary syphilis, which is associated with a number of lesions, including cutaneous rashes, which manifest as dark patches on the skin. The classical intraoral lesions associated with secondary syphilis are known as mucus patches, which are a mixture of white and red patches with or without ulceration. Another lesion associated with secondary syphilis are condylomas, which are basically papillary projections involving the tongue usually and resemble viral warts clinically. Tertiary syphilis has several important oral manifestations, and perhaps one of the more important ones is atrophic glossitis. Tertiary syphilis is associated with atrophy of the tongue, and it is characterized by whitish discoloration of the lingual mucosa. And the important thing is that these changes on the tongue, termed as atrophic glossitis of tertiary syphilis, is actually a pre-malignant condition and has a risk of transformation into oral squamous cell carcinoma. At this point, you might also want to uh, think about other premalignant lesions and conditions such as leukoplakia, erythroplakia, uh, actinic chelosis, and palatal changes associated with reverse smoking. So these are the recognized premalignant lesions. In terms of premalignant conditions, you might want to consolidate your knowledge on oral submucous fibrosis, glossitis of tertiary syphilis, Plummer-Vinson syndrome or Patterson-Kelly syndrome, and also uh, immunosuppression such as that with immunosuppressive therapy or stem cell transplantation can also be associated with increased risk of oral squamous cell carcinoma. Another remarkable manifestation of tertiary syphilis is perforation of the hard palate, uh, which is caused by chronic granulomatous inflammatory lesions known as gumma, which lead to destruction of the soft tissue as well as bone in the hard palate region, resulting in perforation of the palate. However, remember that tertiary syphilis is not the only cause of perforation of the palate, and trauma, particularly gunshot injuries, can also lead to perforation of the palate. Also, malignancies in the region of maxilla, palate, or even the maxillary antrum can on occasions lead to perforation of the palate. The other thing you need to note is this is probably a separate lesion and represents a palatal torus and is not part of the uh, lesions associated with tertiary syphilis. Syphilis can also be transmitted vertically from a pregnant mother to the fetus and is termed as congenital syphilis. Congenital syphilis has several manifestations in the oral cavity, including screwdriver-shaped notched incisors, which we term Hutchison's incisors, and mulberry molars, which represent a mulberry fruit. Syphilis is perhaps the only infectious disease which causes morphological changes in the dentition. So that's quite a key manifestation which you should remember. Tuberculosis is a very well recognized infection which is mainly seen in less developed countries but has a global distribution. It's a chronic infection caused by Mycobacterium tuberculosis, and over a billion people worldwide are affected. Uh, of these, 5 to 10% go on to develop active disease, and it can be potentially fatal. All immigrants from high-risk countries coming to the UK are routinely screened for tuberculosis as part of the immigration process. Uh, in more developed countries like the UK, tuberculosis has been controlled effectively. However, atypical tuberculosis caused by atypical mycobacteria such as bovis, which comes from bovine sources, cattle, for example, and Mycobacterium in avium intracellulare, which comes from birds, uh, pose a risk to countries like the UK because atypical tuberculosis is on the rise in UK. Mycobacteria are classically stained using Zeil-Lensen staining, uh, and you can see the pink colonies of mycobacteria. Uh, you can read more about ZN staining in your self-directed learning, and I'm not going to cover this in this session. Infection with Mycobacterium tuberculosis passes through several classical stages. Primary tuberculosis is seen in previously unexposed individuals and involves the lungs, where it leads to uh, chronic granulomatous inflammation, and the primary lesion is known as Ghon's focus, as in Ghon''S. Then the infection may uh, go into a latent phase and reactivation, which is usually associated with immunosuppression, such as in HIV positive patients. Secondary tuberculosis has pulmonary as well as extrapulmonary manifestations, that it involves the lungs as well as extrapulmonary tissues. And finally, miliary tuberculosis is diffuse disseminated disease which can involve several organ systems such as the CNS, the skeletal system, the bones, and even the skin. One classical example of uh, tuberculosis involving the bone is uh, destruction of the spinal column, the bones of the vertebrae, and you may be intrigued to know that in the good old days, bone destruction of the vertebrae uh, caused by tuberculosis was termed caries of the spine. HIV poses the highest risk factor for progression of infection into active disease. And obviously, you should be uh, aware regarding management of tuberculosis positive patients in dental settings. So you would take extra precautions in regards to barrier techniques such as masks, etc. You would have learned that during COVID-19 pandemic. So extra precautions are required, and also the airflow rates in the surgery need to be monitored. So that's a topic which needs to be discussed in the context of cross-infection control, but so that you're aware that patients with tuberculosis coming to you for dental treatment may require extra cross-infection control precautions. On this slide, you can see the two key manifestations of tuberculosis in the head and neck region. Firstly, an ulcer involving the right ventral tongue, and then cervical lymphadenopathy with uh, fibrosis involving the right neck. So those are the two key manifestations of tuberculosis in the head and neck region. Actinomycosis is an infection caused by gram-positive filamentous anaerobic bacteria. Because these filamentous bacteria form colonies which simulate fungal growths, this infection was initially thought to be a fungal infection, hence the term mycosis, which is to do with fungal infections. But remember, it's a bacterial infection, and actinomycetes are part of saprophytic oral flora, and the infection can be caused by a variety of uh, types of actinomycetes, including Israeli viscosus, Naselundae, and odontolyticus. It may follow an acute or chronic pattern of infection, usually in the cervicofacial region, but may also involve the thorax or the abdomen. Uh, Actinomycosis is preceded by trauma or surgical insults or pre-existing periodontal disease or even poor oral hygiene. Now, the reason why you need to be familiar with this infection is it is characterized by extensive suppuration and fibrosis as the abscesses tend to heal, and it can cause remarkable disfigurement of the face due to persistent suppuration and fibrosis. So on this patient, you can see a cutaneous fistula with discharge of pus involving the right lower border of the mandible, where you can also see adjacent swelling where there is probably another abscess developing, and you can also see evidence of scarring in the submandibular region. So multiple draining fistulae and cutaneous sinuses with discharge of pus and associated facial disfigurement could be indicative of actinomycosis. And if you suspect a patient to have this infection, it may be most appropriate to refer these patients to secondary care so that they can be treated under specialist settings, because these patients would require uh, extensive courses of antibiotics which warrant definitive diagnosis and supportive therapy. So they are best treated in specialist settings, not in primary care dental practices. A remarkable and severely destructive infection caused by anaerobes like Fusobacteria and Prevotella is Cancrum oris or Noma. It is basically a gangrene of the oral soft tissues, uh, and you can do further reading around gangrene. So you may be familiar with dry gangrene or frostbite, which occurs due to exposure to extreme low temperatures uh, as it compromises the blood supply to the limbs. So that's an example of dry gangrene, and where there is a combination of uh, reduced blood flow and infection, it can lead to wet gangrene. So gangrene is basically necrosis of the tissues accompanied by putrefaction or production of foul-smelling toxic products due to bacterial infection. And finally, you may be familiar with gas gangrene caused by Clostridia, which is another type of bacterial infection. Now, you are unlikely to see Cancrum oris or Noma in the UK. It's mainly seen in African countries amongst children who are severely malnourished or immunocompromised. But I've included it here because as a dental professional, you should be familiar with this condition due to the remarkable soft tissue destruction and facial disfigurement it may cause, often warranting extensive rehabilitation, plastic surgery, etc., to which those children may not have access anyway. So just be familiar with this condition, Cancrum oris, which is basically a gangrene of the orofacial tissues. Cancrum oris can involve the soft tissues of the oral cavity, either in isolation or in combination with destruction of the facial tissues. And on this slide, you can see extensive destruction and necrosis involving the left palate, uh, hence the name necrotizing ulcerative mucositis. And substantial healing can be seen following a short course of tetracycline. So ulcerative mucosal lesions can also be seen in the oral cavity with anaerobic bacterial infections. Sinusitis or inflammation of the lining of the paranasal sinuses is common and is usually caused by bacteria. It can be precipitated by a deviated nasal septum, nasal polyps, or a pre-existing respiratory infection. While sinusitis can affect any of the four paranasal sinuses, maxillary sinusitis is of particular relevance to you as dental professionals as it can mimic toothache. Uh, the classical signs and symptoms of uh, maxillary sinusitis include pain and swelling around the cheeks and eyes and the forehead. Sometimes it can be confused with toothache, a blocked nose, and reduced smell or taste perception. Uh, in certain cases, sinusitis can be accompanied by discharge, a purulent discharge from the nose, and a high temperature. And what is interesting is that odontogenic pathology, that is dental infections, account for 10 to 12% of cases of maxillary sinusitis. That is, dental infections can cause secondary involvement of the maxillary antrum. Now, if you investigate using radiographs, you would note that the shadow of the normal maxillary antrum appears radiolucent or black because it's filled with air. But following sinusitis, as inflammatory exudate accumulates in the maxillary antrum, it gives it a hazy appearance. But of course, sinusitis could also be bilateral, so something you need to bear in mind. And another important thing with sinusitis is that bending forward can increase the severity of pain. Sinusitis is usually polymicrobial with anaerobes predominating, and your job as a dental professional is to identify it and refer it to the patient's GP for further management. And the other important thing is you must rule out any dental pathology which may be contributing to sinusitis and manage it appropriately. Tonsils are collections of mucosal associated lymphoid tissue and form an arrangement known as the Weldier's ring in the pharynx. So tonsils include the palatine tonsils, which are bilateral, the tubal tonsils, which are located adjacent to the opening of the eustachian tube in the nasopharynx and are also bilateral. In addition, there is the pharyngeal tonsil located in the posterior wall of the pharynx, and finally the tonsillar tissue in the posterior part of the tongue. Palatine tonsils can get inflamed commonly and are usually a mixed infection caused by beta hemolytic streptococci, staph plus anaerobes, H. influenza, fusobacteria, and porphyromonas. And you should be able to recognize inflammation involving the palatine tonsils if you examine your patient appropriately under good light, and you should be able to refer them to their GP for further management. The oral cavity could also be involved by sexually transmitted bacterial infections, and we've already discussed syphilis in this session. Other examples include gonorrhea, and you can clearly see infection and inflammation in the soft palate region. Now, oral sexual practices can also cause physical trauma to the soft tissues in the oral cavity, particularly in the region of the soft palate and the tongue, and could be complicated by secondary bacterial infections. When taking patients' history for suspected sexually transmitted infections, you've got to be very mindful about the sensitivities involved, and you need to be sensible when asking relevant questions. Obviously, this is not within the scope of this current presentation, but we shall discuss this hopefully in another session, how to take an appropriate history from the patient when you suspect sexually transmitted oral infections. To summarize, as a dental professional, you should be able to recognize the clinical presentation of bacterial infections, and especially for bacterial infections with systemic signs and symptoms, you should liaise with your medical colleagues for appropriate investigations, management, and follow-up.